Okay, I'm going to get started. I'm not sure how you want this done. If you want to sort of ask questions in between, please feel free to do that. Just trying to figure out, is there यहाँ पे chat कहाँ है? Chat.
यूट्यूब में आएगा, इसमें साउंड आएगा गाने का। अनेक क्वेश्चन है, बोलना सर, बोल दो।
Okay, so I mean, actually, feel free to interrupt me by speaking out loud. I'm going to take a while trying to figure out the chat, so that's okay. So let's get going. Traditionally, what happens is that you've already had your pharmacology lectures on the various pharmacological agents which are used for diabetes. And I will repeat some of that part, but I will try and give it a sort of a more clinical perspective when providing the same information to you so that you can perhaps also utilize some of that information as you proceed into clinics. Um, Okay. So the first thing is, and then we need to understand before we treat any disease, is how do you diagnose that disease? And if you were in the lecture theater, I would have definitely asked you a few questions, but unfortunately, that pleasure and privilege is not with me at the moment. But by and large, there are set diagnostic criteria which are based on venous plasma glucose, right? And therefore, when we talk of diabetes, your fasting glucose of more than equal to 126 and a 2-hour post glucose load value. So you give 75 grams of anhydrous glucose. Remember, what you get in the market is glucose monohydrate. So if you want to actually do an oral glucose tolerance test with what is available in the market, you'll need to give 82.5 grams rather than 75 grams, because 82.5 grams or 83 grams of glucose monohydrate is equivalent to 75 grams of anhydrous glucose. So that's the first practical tip if you want to conduct your own GTT, right? The second thing, of course, is that 75 grams of glucose should be dissolved in about 300 ml of water. So a large glass of water, and ideally it should be drunk in 5 minutes. And the clock starts ticking from the moment the person starts drinking. If you've not drunk 75 grams of glucose, I can assure you it's quite nauseating. And a lot of people actually would like to put in a twist of lemon or something in it to make it tolerable, despite which people, a small number, but some people do end up vomiting. Now, the rule here again is, and again it's a practical tip, if a person vomits during a GTT, is that null and void? Um, Typically, what we say is if you vomit after half an hour of drinking that glucose, you should be fine because the absorption would have happened by then. So this is the sort of general practical tips. And during that period of 2 hours of waiting, there should be no physical activity. You should not smoke, which anyway you shouldn't, and you shouldn't be running around. So sit down with a paper or your phone or an iPad and do that. Now, what is normal, and then I'll come back to the in-between business of fasting glucose, depending if you believe in the WHO, the American Diabetes Association, of less than 100 if you believe the American Diabetes Association, or less than 110 if you believe the WHO, and a 2-hour post glucose of less than 140 is what is considered to be normal. And therefore, anything between the normal cut point and what I just said for diabetes puts you in the category of uh, impaired glucose tolerance if you have an isolated elevation of the post-load glucose, right? And this has to be more than equal to 140, but you don't hit the cut point for the diagnosis of diabetes. So 140 to 200 or 140 to 199. And for impaired fasting glucose, as I said, if you believe in the American Diabetes Association, it's 100 to 125. If you believe the WHO, it's 110 to 125. I just wanted to put one thing on record, which is important, that the cutoff for deciding uh, that this is a threshold for saying somebody has diabetes is based on the association of elevated glucose with microvascular complications, namely, in this instance, retinopathy. And I think that's what you really need to understand. How do you say something is normal and how is something abnormal? The best way of deciding normalcy is if you have a biological or a clinical outcome measure which gives you guidance. And therefore, for diabetes, that has been done. The measure here which is used is presence or likelihood of increased risk of retinopathy, and therefore a value of about 126. In different studies, it was somewhere between 120 and 126. So they took that value. It also corresponds to 7 millimoles, so it's a little easy. And that's how this decision of a cut point was taken. And 200 is equivalent to that. Normally, somebody with a fasting glucose in that range will have a post-load value in the vicinity of 200. Okay. Now, in addition to the glucose values, there is one more measure which has been used, which is glycosylated hemoglobin or glycated hemoglobin. And this is if you have a value which is 6.5% or more, and I'll talk to you a little later about HbA1c, because HbA1c has been primarily used for not for the diagnosis of disease, but to monitor control or monitor impact of therapy. But in recent years, it has been used for diagnostic criteria, or therefore a value of 6.5% or more. But there are some specifications in the method that is used. There was a trial called the Diabetes Control and Complications Trial, and a specific method was used based on which there is now in the US something called the National Glycohemoglobin Standardization Program, or the NGSP. And therefore, there are methods which are linked with, which are NGSP certified, and these can be used for diagnosis. In addition to all of this, if you don't want to do a DTT, anybody who has classical symptoms of hyperglycemia, which means, osmotic features of increased thirst, increased urination, increased appetite, with a value of more than 200, also qualify for the diagnosis of diabetes. And I thought we should just put a reminder on this so that, before you treat somebody, you need to know how you can diagnose that somebody with diabetes. Okay. So the two principal defects, and I'm going to make this very, very sort of minimalistic. The two principal defects of type 2 diabetes are, number one, insulin resistance, number two, beta cell dysfunction. And I'm saying this because for all practical purposes, all treatment addresses either one or the other of these defects. So insulin resistance means that insulin is really required to facilitate entry of glucose into the cells, but for some reason, the cells are resistant to this action of insulin, and therefore, despite a higher level of glucose, that glucose is not entering into the cells, is not being utilized for energy generation. That's insulin resistance. You have a group of agents which reduce the resistance or are called insulin sensitizers. The second category, of course, is if there's an insulin secretory defect, that there is not enough insulin being produced by the cells. In this instance, you have drugs which are called secretagogues, which cause release of insulin from the pancreatic beta cells. And these are by and large the two main mechanisms by which oral hypoglycemic or anti-hyperglycemic agents work. Let's take you through two other important things before I shift to pharmacotherapy. One is diet and one is physical exercise, right? You need to understand that there are a few components of diet which are critical. Again, simplistically put from a clinical perspective, it's how much you eat, what is the timing of that, and what is the spacing between meals. So if you eat large amounts of food, you're more likely to have higher sugars. If you eat the wrong sorts of food, which could be, a lot of fat, refined carbohydrates, free sugars, again, you're more likely to have high sugars. if your timing is such, sorry, not timing, but the way you divide your dietary intake. So if I take the right amount of food and I take the right things, but I have two large meals in a day, versus I divide the same quantity into three major and three minor meals, my sugars will be obviously lower when I have multiple meals, because at no single point of time am I taking a large amount of food. The last thing is, how do you space these meals out? Now, some people, for religious purposes, for other purposes, will eat only between sunrise and sunset, right? They will not eat after sunset. So they may be taking the right amount of the right sort of meals, dividing it into multiple points, but there will be crowding of meals because the total time over which they distribute their caloric intake is less, and they are also likely to have a higher glucose value. So these are the four things you look at. The concept you have to be familiar with is glycemic index, and basically this concept indicates the extent of rise in blood sugar in response to a food in comparison with the response to an equivalent amount of glucose. So let's say I take 25 grams of glucose and I take 25 grams of another food item which contains, rather I take another food item which contains 25 grams of carbohydrate, right? So that could be a roti, it could be an idli, it could be an uttapam, it could be, a bowl of dalia. And really what we need to see is, in comparison to the glucose rise which is seen when I have 25 grams of glucose, and I've just given you that number, it could be anything. How much does this equivalent amount of carbohydrate in a non-glucose form cause a rise? And clearly what happens is, things which are more complex, which need time to be broken down, will have a lower glycemic index because it takes time to break the food down into constituent monosaccharides, which is then converted into glucose, as opposed to refined carbs, which may have a very, very sharp and dramatic rise. So glycemic index is important when you're trying to explain things to patients. It's also important that you can dampen the rise of a food item which otherwise causes rise. So, traditionally it's felt that white rice is responsible for a very sharp rise in glucose. But if I take that white rice with dahi or yogurt versus I mix that rice with with a lot of vegetables and dal and other stuff, the same rise which I see with rice and yogurt will be less when I have the same rice with other additional food items. So again, there is not only the concept of a glycemic index of a food item, but that can be varied by adding stuff to it, right? Then there's a concept of glycemic load, and that's is basically a product of glycemic index with the amount of carbs. So let's say the glycemic index of bread is 90, but then if I'm having 3 slices of bread, each one was 20 grams, so I multiply that and I get a full glycemic load. Fiber is something which we are very keen on in management of people with diabetes because it is not digested by the gut. It's the soluble fiber may still give you a little bit of carbs. The insoluble fiber will not provide you any carbs. It also retards the breakdown of carbohydrate from the rest of the food it is in. So dietary fiber, and therefore, if you look at studies in which prevention of diabetes has been done, and for people who have diabetes, people will recommend 10 grams of fiber per 1,000 calories of food intake. So the higher the fiber intake, the better it is. So I already mentioned this to you. Small frequent meals, space them out, small quantity and the right sort of stuff. Consume a range of fruit, vegetables and grains. Limit the intake of food which are high in saturated fats. Trans fats, of course, are a no-no. And substitute with polyunsaturated and monounsaturated fats. And therefore, fruits and veg and low-fat dairy products are actually good for advice. Exercise, especially aerobic physical activity, is useful. And what I've shown on this slide are the WHO guidelines for adults in general. This is not even specific to diabetes. It used to be 150 minutes of moderate intensity aerobic physical activity in a week, but they've increased that to 150 to 300. So 150 was based on half an hour per day for at least 5 days a week. They've increased it to double of that. You can reduce the duration by increasing the vigor or the vigorous intensity. So instead of moderate intensity 150 minutes, you can do vigorous intensity 75 minutes. You are also encouraged to do muscle strengthening activities. Remember, toning muscles versus bulking up muscles are very different. These are strengthening exercises, not exercises to make the muscle bulk. And a couple of days in a week for the major muscle groups is fine. The other thing is also limit the amount of time being sedentary, right? So sitting, as they say, they keep saying tobacco is bad, then sugar is the new tobacco. Sedentariness, that is sitting, is the new tobacco. So don't sit. If you can stand and work, so people like working on stand-up desks, people like walking and doing stuff. So avoid sitting and lying as much as possible. Okay, I'm going to shift to the pharmacology part here and talk to you about the management of diabetes. The first thing I'd like to emphasize is that the impression that managing diabetes is the same as managing glucose control must be removed from your mind. So management of diabetes is not glucose centric. But for this seminar, I will concentrate primarily on agents which are there for managing glucose, because the other categories of agents will be covered in other lectures, right? So the important thing is management of type 2 diabetes involves addressing obesity, addressing lipids, addressing hypertension, and tobacco, right? So it's not that you can allow glucose to be, you can focus on glucose but allow blood pressure to remain uncontrolled and cholesterol to remain uncontrolled. That needs to be done. Similarly, an obese person must be encouraged to lose weight. Similarly, any form of tobacco consumption, smoking or smokeless, has to be immediately curtailed and stopped, right? So this is our risk stratification of lipids in an adult with diabetes. Essentially, if you look, we now normally like somebody who has diabetes to have an LDL of less than 100, right? And a triglyceride of less than 150. So that's what you really need to focus on. Forget about the high risk, borderline risk, but the target for therapy. And therefore, if you have a patient in whom after starting lifestyle intervention, and diet and physical activity normally can bring down LDL cholesterol by about 30. So if you're in the vicinity of about 130, you can actually hope that the LDL cholesterol can come down to about 100. Triglyceride is the secondary target. So you first bring down LDL. If LDL is controlled and TG persists, then you focus on TG. And the TG target has to be less than 150. HDL cholesterol should be more than 45 in men and more than 55 in women. Let me acknowledge that Indians have this tendency of having low HDL, whether men or women, and there are really no good agents which not only improve HDL but also improve cardiovascular risk, right? So we've used nicotinic acid in the past, which does increase the HDL values, but the cardiovascular outcomes don't seem to improve with that. So we are stuck with HDL, unfortunately. The only thing which really works is physical activity. Okay. So the four categories of individuals in which we would consider statins are anybody who has clinical atherosclerotic cardiovascular disease, independent of what their LDL level is. because the belief is that even if their LDL level is 100 and they have clinical atherosclerotic disease, that 100 is too much for them, right? So anybody with clinical atherosclerotic cardiovascular disease, anybody who has a primary elevation of an LDL more than 190, but in a person with diabetes, gosh, and this has got very badly mistyped, anybody with an LDL cholesterol of between 70 to 190, even without atherosclerotic disease, you will treat. And of course, you have one more category, which is very difficult for us to, 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 to actually ascertain in our context, because we don't have very good CVD risk scores. For example, in the US, you would have something like the Framingham risk score. In the UK, the British Heart Foundation. In New Zealand, they have their own. We don't have an India specific score. There is a WHO score which gives you a 10-year atherosclerotic cardiovascular disease risk. But so if you have an ASCVD risk of more than 7.5% over the next 10 years, that person is also a candidate for statin therapy. Treatment goals for hypertension, once again, you want blood pressure to be controlled less than 130/80 in somebody who's got diabetes. If there's isolated systolic hypertension, you need it below 160 or a decline of more than 20, right? So that's how you look. And that isolated systolic hypertension is usually a problem seen in the elderly. So obesity management by weight loss using diet and physical activity, blood pressure control with a target of 130/80 in most individuals, lipid control with a target of less than 100 in most individuals and less than 70, I'm talking of LDL cholesterol, in those who have active atherosclerotic cardiovascular disease. Right. So I'm going to now shift to the glucose end of things, which is what I'm primarily trained in. And the first thing you need to understand is that before the arrival of glycosylated hemoglobin, it used to be very difficult to be able to measure if a drug is useful or not, because you can't do sugars every day in somebody when they're started on a drug. With HbA1c, the advantage is that you can get a composite measurement of glucose control over 3 months, and therefore it's an excellent way of doing that. It's a non-enzymatic glycosylation of proteins on the hemoglobin molecule, and we say it gives you an idea about control for 10 to 12 weeks because that is the lifespan of RBCs. So situations where the lifespan of RBCs is changed, whether it's hemolytic anemia because of hemoglobinopathies, because of whatever, glycosylated hemoglobin is not a good measure for glucose control. So you have to be clear that you're not facing any of these situations. So anemia, especially when there's a low turnover anemia, may have a falsely low disease. A high turnover state may give you a falsely elevated. If you have polycythemia because you're living, let's say, at a high altitude, you may get a falsely high glycosylated hemoglobin. So remember, it is not and sort of without its own limitations. So what are our targets of glycemic control? I won't go into the nuances, but for a standard patient of diabetes, you want a pre-meal sugar of somewhere between 80 and 120 milligram percent, and you want an HbA1c of less than 7%. I'm giving you very broad guidance, and that's from one advisory agency. From another, it's a little bit tighter, a pre-prandial or a fasting less than 110, and a 2-hour post meal. This is not a GTT, so you don't do GTTs on follow-up. GTT is only used for diagnosis. Follow-up is based on a post-meal value, and some people will say 120 to 160, some people will say less than 140. And this particular advisory says a target A1C of less than 6.5%. which for a lot of people may be a bit too tight because it may also end up exposing them to a risk of hypoglycemia. So the personalization of targets will depend on the age of the patient, their comorbidities, their ability to manage and recognize hypoglycemia, their ability to monitor and measure glucose at home, and therefore the top recommendation of a pre-meal 80 to 120 and an A1C of less than 7% is a reasonably generic recommendation which can be accepted for most groups of people. And why we actually came up with this particular story is, and I mentioned that before, that tight glucose control is associated with a reduction in diabetes-related vascular complications, primarily microvascular complications, primarily retinopathy, to some extent nephropathy, right? But there is also a beneficial effect on macrovascular complications, which is further enhanced and significantly enhanced by concurrent management of hypertension and lipids. So really, the trinity of control is managing glucose, managing blood pressure, managing lipids. If I was to take an oral anti-diabetic, so if I was to take an agent to reduce my glucose, what would I want? A, I want it to be oral. I don't want an injectable. I want it to be efficacious. It should control both pre-meal and post-meal sugars. I would want it to do it fast. I would want it not to be associated with hypoglycemia, not to be associated with weight gain, not to be associated with any cardiovascular risk, not to be complicated in terms of the way I have to take it or the number of dosing, so that my ability to comply with the advice is better, and that it should work whether it's in an elderly population, in a cardiac patient, in a polymedicated patient, or a renal impaired patient. Really, I mean, clearly, if I could get by taking one tablet first thing in the morning and be done with it, and all the rest of my day I was fine and my sugars are well controlled, that's what I'd really want to. Now, from the time I was an undergraduate to the time you're undergraduates, there has been a significant improvement. So there are medication which meet most, if not all, of these criteria. But having said that, they're also quite expensive in many instances, and therefore you've got to weigh these positives with economic considerations while taking a choice of medication. So that's really the list of agents. Again, when I was an undergraduate, and I realize that's many, many years ago, but only the first two bullet points were really available: sulfonylureas and bioguanides. That's it. So your misfortune is that you have to learn an extra 7 categories of agents. I managed to pass my pharmacology exam by just knowing sulfonylureas and bioguanides. You will have to know thiazolidinediones, which are the glitazones, alpha-glucosidase inhibitors like acarbose, meglitinide analogs like repaglinide and nateglinide, DPP4 inhibitors, which are the gliptins, SGLT2 inhibitors, which are the gliflozins, and now the GLP-1 analogs, which primarily are injectable preparations but an oral preparation, has also emerged, not available in India, but available in some countries. So I'm going to break this down now in 2 parts. The first, to give you a broad overview of the category, and then break down this, then a bit more detail of each category. So the sulfonylureas are secretagogues. They stimulate insulin secretion. The current ones in use are the second or the newer generation, which include glibenclamide, glipizide, gliclazide, and glimepiride. And they actually reduce HbA1c pretty well, about 1.5%, right? The problem is anything which causes insulin release will have a tendency for sugars to go below normal. Anything which causes hypoglycemia will then cause a person to eat to counter the hypoglycemia, and therefore may also be responsible for weight gain. So hypoglycemia and weight gain become the 2 most important undesirable effects of sulfonylureas. There are non-sulfonylurea insulin secretagogues, the glinides, which is repaglinide and neteglinide, relatively milder. I think nearer 1% than 1.5% for repaglinide. Neteglinide is even milder than that. And they are short acting, so they're less likely to cause hypoglycemia. Amongst the biguanides, metformin, and in earlier days there used to be another agent called fenformin, but that of course is now out of the picture. I've never seen or used it. So it was metformin. It is an insulin sensitizer, again a very good agent. In fact, metformin is first line therapy for type 2 diabetes. Every algorithm will say diet, physical activity, and then the first agent to use is metformin. Thiazolidinediones or the glitazones, we had two which were in the market at one point, which is Pio and Rosie. Rosie is gone for concerns on cardiovascular issues. These are peroxisome proliferator agonist receptor agonists, PPR gamma agonists. They are sensitizers. They're not very strong in reduction of A1C. They're also relatively slow. So when you start them, it takes about 3 months to see their final effect. Alpha glucosidase inhibitors don't affect either insulin resistance or insulin secretion. So they're not part of the primary pathogenetic pathway of diabetes. All they do is they slow the breakdown of carbohydrates. And therefore, the absorption of carbohydrate in the blood is slow, and it's a blunted rise in the glucose peak as opposed to a sharp rise. Now, in our diet, which is a lot of carbohydrates, it may be useful. But if there is a lot of undigested carbohydrate which stays in the gut for a long time, flatulence and gas production can be a limiting problem, which a lot of people will describe. GLP-1 analogs these are injectable. As I said, semaglutide is a new one which is now also available as an oral preparation, but otherwise exenatide, liraglutide are daily, dulaglutide is weekly. There is an injectable semaglutide which is weekly, and then there's an oral semaglutide which is daily. They are smart agents, right? They stimulate glucose-induced insulin secretion, and therefore they are less likely to cause hypoglycemia. In fact, the belief is that they don't cause hypoglycemia because only when the glucose levels are high will they induce insulin secretion. They reduce A1C not significantly, but in some Indian studies, about a percentage A1C reduction has been noted. The DPP-4 inhibitors are so GLP-1 really is a peptide which circulates, but is broken down by this enzyme dipeptidyl peptidase 4. So what the DPP-4 inhibitors do is that they inhibit the enzyme and therefore prolong the circulating time of endogenous GLP-1. And they also stimulate glucose-induced insulin secretion. Sitagliptin, vildagliptin, saxagliptin, linagliptin, teneligliptin, and gemagliptin are available, and they're all in use in India. The newest kids on the block are the sodium glucose transporter 2 inhibitors, or SGLT2, which are predominantly present in the kidney. And what these agents are doing is permitting release of or passage of glucose in the urine at values below the threshold. So normally, as you know, when circulating blood glucose crosses 180 or 200 milligrams per deciliter, you start getting glycosuria. So that's why you do a urine dipstick. Glucose positive means the sugar must be more than 200. The SGLT2 inhibitors allow glucose to pass into the urine at lower glucose values also. There are 3 or 4 of these available. I'm sure there are a couple more in the pipeline. So DAPA, canagliflozin, and empagliflozin. There is an Indian sort of variant called remogliflozin. They inhibit glucose reabsorption, cause glucosuria. I think they've actually acquired a lot of prominence in recent months because in addition to their glucose control, they seem to be A, heart beneficial, so they reduce CV risk, and they have been shown to be beneficial in cardiovascular outcome trials. And secondly, in some of these have actually been shown to prevent progression of diabetic kidney disease. So again, positive things about these agents. Let me now take you through each of these categories in some detail. So, as I said, glibenclamide, glipizide, gliclazide, glimepiride are the second generations. The early generations were tolbutamide, chloropropamide. We don't use that. They are more potent. They're about the same efficacy. So, if you're giving maximum dose of one of these sulfonylureas and it's not doing its job, it's not being sensible to replace it with another sulfonylurea, it's not going to happen, right? They basically act at the voltage dependent potassium ATP channels. They close these channels. They open the calcium channels in the process. Calcium comes in and calcium causes insulin release. I won't worry about the details. The slide will be available in all your pharmacological textbooks. But important that the three commonly used ones, glipizide, gliclazide, and glimepiride, are all passed significantly in the urine, and therefore people who have reduced renal function, you must be extremely careful about use of these agents because they may accumulate in the body, and the accumulated amount may then cause hypoglycemia. Glibenclamide, about 50% is a bile excretion, but it's actually very potent, and it's much more likely to cause hypoglycemia than all these other agents. And therefore, most people have now given up using glibenclamide, except in a younger population. It's the oldest of these agents. It's the cheapest of these agents. And therefore, in a young population, it has its own benefits. As I said, compared to placebo, it reduces A1C by 1 to 2%. Similar reduction by different SUs, so there's no advantage in changing one from the other. In long-term studies, very clearly, microvascular risk reduction has been shown, and there is maybe some element of risk reduction for macrovascular disease. As I mentioned, anything which causes insulin release may cause hypoglycemia and therefore may cause weight gain. So weight gain is a concern with sulfonylurea. Hypoglycemia is again a concern, which is most likely to infect the elderly and in those with worsening renal function and irregular meal schedules. So if I'm a surgeon, I take my sulfonylurea in the morning, have my breakfast in time, but I cannot have my lunch in time because I'm scrubbed up, I'm likely to go into hypoglycemia. As mentioned, glibenclamide is the one which is most likely to cause hypo, glipizide less, and the others even less. Glimepiride appears to be the most weight neutral of these agents, right? The other thing which you must remember about this is that let's take gliclazide as an example. So gliclazide, the entry dose is about 80 milligrams, the maximum dose is 320 milligrams. The dose response curve, when you start increasing gliclazide values, is of a particular slope till you reach 50% of the maximal. Once you go beyond 50% maximal, so once you go beyond 160, the response starts tailoring down, right? So you will not have the same steepness of the slope of the dose response curve. So if you had X as a reduction in glucose when you increase from 80 to 160, you'll possibly have 0.5 or 0.6x as a reduction in glucose when you further escalate it from 160 to 240. So half maximal, till you go to half maximal, you get your best results, and then it starts becoming less. These agents are approved as monotherapy, and they can be combined with all other oral agents, but not with another non-sulfonylurea secretagogue. So there's no point combining a sulfonylurea with repaglinide, right? You can also combine it with insulin. Metformin primarily affects hepatic gluconeogenesis. To some extent, also affects peripheral glucose utilization. Primarily, these are insulin sensitizers. no weight gain, virtually no hypoglycemia. There used to be an older agent called fenformin, which is no longer available. The A1C reduction is about similar to sulfonylurea's 1 to 2%. Very clear benefit in vascular risk reduction, especially macrovascular risk reduction. Right? Now, there's a bunch of contraindications, and I will spend a moment on these. Really, if the renal function is impaired, and I'll dilate upon that in some detail in the next slide, or there are conditions which are likely to cause systemic or regional hypoxia, right? So if you're in congestive heart failure, in respiratory failure, a severe infection causing a local problem, gangrene, all of these are contraindications to metformin use. Use of intravenous radiographic contrast media in large amounts. So somebody going through a coronary angiogram, contraindicated. If you're undergoing surgery tomorrow, definitely don't have your tablet on the morning. Some people used to say that you need to withhold metformin from 24 hours before. Over a period of time, we've become more brave, and we continue metformin not uncommonly till the night before surgery, but then definitely not on the day of the surgery, because general anesthesia with metformin can be, again, a disaster. These are all situations where you can have lactic acidosis with metformin. In addition to lactic acidosis, which is very, very rare, and it will happen only because you overlooked a contraindication. Now, patient is in congestive heart failure and you're giving them metformin, you will increase the risk. If there are no contraindications of metformin use, it's very unlikely to cause lactic acidosis. In fact, the commonest side effects are gastrointestinal, so nausea, vomiting, diarrhea, anorexia, which can be very, very common. Now, this is a little bit of time you need for this is instead of using an absolute creatinine value, we now use an estimated GFR to decide whether or not you can give metformin. So if your eGFR is more than 60, no problems at all. If it's between 45 and 60, if the person is already on metformin, continue. Just if you normally do a renal function monitoring annually, maybe do it every 3 to 6 months. If the person has an eGFR between 30 and 45, we curtail the maximum dose. If usually the maximum dose is 2 grams, we bring it down to 1 gram. If you're already on metformin. If you're not on metformin, we say don't start it because you don't know how soon they'll drop below 30, and anybody who's below 30 cannot be given metformin. Right? 30 is the eGFR level, right? So eGFR less than 30, no metformin. Between 35 and 45, if not on metformin, don't start. If on metformin, max it out at 1 gram. Above that, with varying degrees of monitoring, you can continue the full dose. It can be given as monotherapy and it can be combined with everything. Sulfonylureas, other secretagogues, TZDs, DPP-4 inhibitors, SGLT2 inhibitors, and insulin. So actually, it's a very versatile drug. The alpha glucosidase inhibitors are really, agents which don't act on any of the primary pathogenetic mechanisms of diabetes, right? So they are effectively inhibit alpha glucosidase on the small intestinal blush border. Again, you don't need to know what's written on the slide except for the practical politics of prescribing. Even if you want to give people, so the tablet acts on the meal with which it's given, right? So if you give one tablet with breakfast, its effect will be on the breakfast meal. It will not be on the lunch meal or the dinner meal. So effectively, if you want to give it to cover all 3 meals, you will have to give a tablet with each of the meals. Now, the practical issue is if you start with all 3 tablets on the first day, the patient will not tolerate it. Because there will be such a lot of gaseous distension and flatulence that they will invariably stop it. So the prescription should be as follows. Start with the first bite of 1 meal. So they are to be given with the first bite of the meal. So let's say I give it with breakfast. I then wait for 7 days, then add it with the second meal, which could be lunch or dinner, whatever I want. Then I wait for another 7 days and add it for the third meal. So even if your target is a tablet with each meal, do not give it on all three meals from the very beginning. Increment after a week. And that's the important thing you need to remember. It's not really, it helps in people who have high carb intakes. It's definitely less effective than other agents. And the maximum effect is on post meal sugars. It has very little effect, if any, on fasting sugars, right? There are virtually no studies which have examined its long-term effectiveness on complications. As I mentioned several times, the adverse effect is flatulence, is usually given in combination with other agents. The only other practical issue which you must remember is that normally if you have, people having hypoglycemia, they won't have it because of these agents, but let's say they're combined with insulin or with sulfonylurea and the patient has a hypoglycemia. If the patient takes sugar to counter the hypoglycemia, the effect will get delayed because the sugar is also broken down by alpha glucosidase. So if you are on alpha glucosidase inhibitors and other agents which can cause hypoglycemia, you must tell the patient that they should keep glucose with them because countering hypoglycemia in them will require glucose and not a disaccharide because the disaccharide will take a long time to get broken down. These are the meglitinide, which basically act on, again, they act on the ATP regulated potassium channel, but they have a different binding site on the beta cells. So they don't interact with sulfonylureas, but they eventually, if you're on a maximal dose of sulfonylureas, you will get no benefit in adding one of these agents. And there makes no sense to combine two secretagogues, right? Their biggest advantage is they're short acting. So if I have an erratic schedule, I gave you the example of a surgeon, or if I'm a traveling salesman, I have breakfast and I'm not confident when I'm going to have lunch. These are nice agents because they act for a short period of time. So I can take one tablet with breakfast, one tablet with lunch, one tablet with dinner, right? Their duration is short and therefore they need to be given by multiple dosing, but they reduce the likelihood of hypoglycemia because their effect tails off. So even if lunch is late, the effect of the morning tablet would have gone, so the likelihood of hypoglycemia becomes less. I wouldn't really worry about the doses, etc. But as I mentioned, hypos are rarer. Weight gain is also uncommon. Right. Shifting to the glitazones, as high as already in diones, the peroxisome proliferator activated receptor, gamma agonists. So there are PPR alpha agonists also, which are the fibrates which act on triglycerides. There is an agent called saroglitazar, which is another PPR alpha agonist, which has been used for glucose lowering, but more importantly and more recently on triglyceride lowering. But these are PPR gamma agonists, which are predominantly acting on glucose lowering by an insulin sensitizing effect. Weight gain is important because they actually cause adipogenesis. Primarily, peripheral adipocytes are affected. The visceral fat is not increased. They also cause edema, especially if you give them along with insulin, and they can cause anemia. So they're not really good agents if you have already class 3 or class 4 symptomatic with congestive heart failure because they will cause edema and they may actually precipitate failure. A more recent side effect which has been noticed is fractures because they divert the mesenchymal stem cells towards adipocyte production away from the osteoblast and osteocyte production, right? So fracture risk is supposed to be slightly higher with them. It's been approved for a range depending on which country you are. The FDA has allowed it as monotherapy. The NICE, which runs the UK guidelines, has no monotherapy, but only combination with sulfonylureas and metformin. Rosiglitazone, which is around for a while, has been shown to be associated with congestive heart failure and is no longer approved. There is also a limited prescription advisory in India for PIO because there had been some concerns about the relationship of pioglitazone with bladder cancer. Not sure how much that has been borne out, but people are reluctant now to give a larger dose of pioglitazone. Most people stop at 15 milligrams, but definitely not more than 30 milligrams. Previously, we used to go up to 45 milligrams. Coming to the new sets of agents, the GLP-1 receptor base. So these are either the dipeptidyl peptidase inhibitors or the GLP-1 analogs, and I've told you about both of them. The primary thing you need to understand is a concept which is called the incretin effect. What has been described is that if you give a certain amount of glucose IV and an equivalent amount of glucose orally, the insulin generation is much more with the oral glucose, and that is attributable to the topping up effect of GLP-1, which then also causes insulin secretion, right? So which does not happen with an IV glucose. So this observation, which was made 30 years ago, has been used now identify that as GLP-1, a glucagon-like peptide 1, which is responsible for this. That means it can cause insulin release, and therefore two categories of agents. Obviously, one, an agent which can bind the GLP-1 receptor and mimic the action of GLP-1, or DPP-4 inhibitors, which prevent the breakdown of endogenous GLP-1, have been used for treatment. The other important observation was that the incretin effect is lower in type 2 diabetes as opposed to the normal population, and therefore this is an important target for therapy. Whole bunch of agents, Sita, Vilda, Saxa, Lina, Gemi, Tinelli. I won't go into their details. They are weight neutral or cause weight loss. There is no hypoglycemia, and they can be used with a bunch of agents. So actually, they're pretty popular. More so now that a couple of them are off patent and they are less costly. When they started, they were pretty expensive. GLP-1 analogs are all derived from, but not derived from that, but the first prototype molecule was called exenatide. Exenatide is similar to an agent called exendin. Exendin was first seen in the saliva of a lizard called the Gila monster. Now, the funny part about this lizard was it had protracted periods of hibernation, right? So it would eat and then sleep. And it was felt that storing the food was better utilized by the Gila monster, and then glucose was released by salivary exendin in this person. So they developed the first molecule mimicking exendin, which binds the GLP-1 receptor. It is resistant to the action of dipeptidyl peptidase 4, so it can act for up to a day or at least 12 hours. So the first agent was exenatide, which was given twice a day. Then people started giving liraglutide, which is once in a day. Now we're using dulaglutide, which is a weekly variant of exenatide, and semaglutide, which is a weekly variant of liraglutide. So these are all GLP-1 receptor, GLP-1 agonists with different durations of action. The biggest problem with this is that it causes a lot of nausea in people. And therefore, very often you start with a small dose and then do a gradual increment after that. Shifting now to the last category of oral agents, which is SGLT2 inhibitors. The two sorts of sodium glucose cotransporters, SGLT1, which are mostly present in the intestine, and SGLT2, which are nearly entirely present in the kidney. The ones at the kidney are useful for glucose absorption. Therefore, if you inhibit that, the absorption, the glucose starts passing in the urine, right? This is showing the same thing, that this is present in the proximal tubule and reabsorbs 90%. Whatever is left is then reabsorbed by a little amount of SGLT1 which is present there, so that all the glucose is retained for use in the body and there's no glucose which normally passes out in the urine. If the glucose value in the blood is high, it saturates the ability of these transporters and you start getting glucosuria. But if you inhibit SGLT2, you will find that even at lower values of prevailing glucose, you will cause glucosuria. So really all it's doing is shedding the higher value of glucose in the urine. It's not affecting a primary pathogenetic mechanism at all. So they're basically causing osmotic diuresis, and therefore there may be some reduction in blood pressure. They do cause weight loss, and because they're working by just shedding the extra glucose, they will not cause hypoglycemia if given as monotherapy. The problem which you need to watch out for is that if the urine contains glucose, it becomes a fertile culture medium, right? Because bacteria will love the glucose, the fungi will love the glucose, and therefore there is a higher likelihood of UTI and higher likelihood of genitourinary fungal infection. So what we normally tell our patients is that every time they pass urine, they should wash their external genitalia so that there is no urine left there, which would then expose them to a higher risk of infection. And that by and large takes care of this particular problem. Uh, Again, the names of agents, I won't worry so much about this because this would be available. So DAPA, canagliflozin, and empagliflozin are the three agents. Most of them, like DAPA and EMPA, come in 2-dose strengths, 5 and 10. EMPA traditionally is given either 10 or 25. And Cana, though it's written as there are different doses, we by and large stay with 100 milligrams. They can be given once in a day. And that's another plus point. The issue which you need to understand is that they are dependent on glucose filtration, right? And therefore because glucose has to be first filtered and then reabsorbed. So if the glomerular filtration rate is low, people are in renal failure, they become less efficacious. So for all of them, it's recommended that you can continue till the EGFR is 45, maybe 30. Below 30, it's unlikely to be beneficial for a glucose lowering perspective, though there are studies which now seem to indicate that for preventing progression of kidney disease and for heart failure, even lower EGFRs may be amenable to the action of the gliflozins. But for glucose lowering effect, anything below 30 definitely doesn't work. Maybe between 30 and 45 also, they're not that efficacious. Right. Now, people with type 2 diabetes, right? When you start, especially when there's an obese type 2 diabetic, in the beginning, you can have a response to diet and physical activity, then you need one tablet, then you need another drug, then you need another drug. But over a period of time, there's progressive beta cell failure. It can happen in 10 years, 15 years, varying lengths of time. Now, this is the curve from the United Kingdom Prospective Diabetes Study, which actually had recruited people within a year of their diagnosis of diabetes. And it basically back calculates beta cell function. And it appears that, by about 10 to 12 years from diagnosis, a large proportion of people will not be producing adequate amounts of insulin, and therefore oral agents are unlikely to be efficacious. And that's where insulin will be required. Now, indications for insulin in type 2 diabetes can be short-term indications or long-term indications. Anybody with type 2 diabetes who goes through an acute situation, has an MI, has surgery, has burns, has acute metabolic decompensation, um, a diabetic woman who's contemplating pregnancy, all of them will benefit from insulin, but that insulin can be given for the period which that acute situation continues. So they recover from an acute myocardial infarction, they can go back to their oral agents. When they recover from their surgery, they can go back to their oral agents. When the pregnancy finishes and lactation finishes, the pregnant woman with type 2 diabetes can go back to the oral agents. Then there is another category in which you need to give what used to be called secondary OHA failure, that there's not enough insulin being produced. Henceforth, they will require insulin either added on to their oral agents or a replacement for their oral agents. And that's what we need to really understand. So you can use different, so insulins, as you know, are different sorts. You have short-acting insulin or short-acting insulin analogs, intermediate or long-acting insulins and long-acting analogs. So you can give a combination of a very common regimen for type 2 diabetes is a premixed insulin in which 30% of the mixture is short-acting insulin, 70% is a long-acting insulin. You give it twice a day, and that really takes care of management of type 2 because they have some endogenous beta cell reserve, and giving 2 shots takes care of the problem. Right? I will not want to go into more detail about insulin here. I'll talk a bit more about it when I shift to type 1 diabetes. So let me wind up with type 2 diabetes and give you an algorithmic approach, and I think it's important. So as I mentioned before, after diet and lifestyle management, virtually every algorithm will say metformin is the first line treatment. Metformin has high efficacy. It has low or virtually no risk of hypoglycemias. It doesn't cause weight gain. In fact, in a few people, it actually causes weight loss. There's significant GI side effects, but it's a cheap agent. And it's a favored agent everywhere in the world, right? So that's the first agent. Monotherapy, if you want to do, that's the first agent. Of course, there will be situations. Let's say somebody has renal failure and you find them. You cannot give metformin. Right? Somebody's intolerant to metformin. After trying it, you need to shift to another agent. But otherwise, monotherapy is usually metformin. If you need to add a second agent, because if the HbA1c target is not being met, you can actually add anything else with metformin. Sulfonylurea, thiazolidinedione, DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 receptor agonist, or basal insulin. So just one shot of long-acting. Now, there are different benefits and risks for all of these combinations. For example, if you add a sulfonylurea, efficacy is very high, but there is a definite risk of hypos and weight gain. If you add it with thiazolidinediones, there is a problem with edema. If you add it with a DPP-4 inhibitor, actually there's not a huge lot of problem, but they're not very efficacious compared to something like sulfonylureas. You can add it with an SGLT2 inhibitor, as again, the efficacy of them in terms of glucose lowering is not significant, but your concerns are about genitourinary infections and, because of osmotic diuresis, dehydration. You can combine it with GLP-1 receptor agonist, but the GI side effects can be crippling because both metformin and GLP-1 receptor agonists can have GI side effects. Or you can add it with a single shot of basal insulin, but then the risk of hypoglycemia comes in. So let's say you've added it to one of these, sugars are still not controlled, you go to triple therapy. If you had already started metformin and sulfonylurea, you retain the option of adding any of the other agents, TZDs, DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, or insulin, right? Any one of these. Similarly, if you had thiazolidinediones, you can add any of the others. So instead of sulfonylureas, DPP4, SGLT2, GLP-1, insulin. If you'd added DPP4 inhibitors, there is no point, just like you don't combine sulfonylureas with a non-sulfonylurea secretagogue. So you don't combine a sulfonylurea with ripaglinide or neteglinide. Similarly, you do not combine a DPP4 inhibitor with a GLP-1 receptor agonist because they're both acting through the same pathway. Except for GLP-1 receptor agonist, you can actually use any of the others as a third agent. Similarly, if you're adding a SGLT2 inhibitor, right, you are usually advised not to either, and you want an oral agent, you will use DPP4 inhibitors, but you will not use a GLP-1 receptor agonist. If you were already added a GLP-1 receptor agonist out here, you can add either a sulfonylurea or a TZD or insulin, but you don't add an SGLT2 inhibitor or DPP4 inhibitor. And if you added insulin out here, you can actually add anything, but there is no real point of adding a sulfonylurea if you've already added insulin here already. But the important message for you is metformin is the first line. If it doesn't work at the maximum tolerated dose, any of the agents, and then for the third line, you will need to be restrictive because you don't combine some of these with each other. Obviously, if none of this works, add insulin, right? Okay. Now, if your concern is hypoglycemia, right, which can be if a person has hypoglycemia unawareness, in an elderly person, because hypoglycemia can cause them to fall and break a bone, then you modify the algorithm. You're starting with metformin, but at least to start with, when you want to add a second agent, or you will avoid a sulfonylurea or you'll avoid insulin, right? And if you then need a third agent, you will then accordingly not add either a sulfonylurea or insulin in the mix, and the other agents will continue as per the previous slide. So that's when you're concerned about hypoglycemia. If you're concerned about weight gain, then your choices become even less. You will not add a sulfonylurea, you will not add a thiazolidinedione, you will not add an insulin as second line, and then that gets expanded as you go on to third line. So really depending, and I would actually say if cost is important, and this is the most important for you and me because we have a population which is often not well off, then DPP4 inhibitors, SGLT2 inhibitors, and GLP-1 agonists are actually expensive agents, right? So then you're left with sulfonylureas, thiazolidinediones, and insulin, and different combinations of these as second or third line. The other agents become lower, not because they're bad, they're clearly good, but the average patient who's paying out of pocket cannot afford. So just remember, there's a standard algorithm, first line, second, dual therapy and triple drug therapy, and then that gets modified depending on if your concern is hypoglycemia, weight, or cost. Okay, I'm going to shift to type 1 diabetes now. And take you through this, which is really a different kettle of fish altogether. The first message is there's only one agent which you use here, which is insulin, nothing else, right? So this is Banting and Best, who really were responsible for isolating and using insulin for the first time, got a Nobel Prize for that. And this is the first patient, his name was Teddy, I forget his surname, who, as you can see, before insulin therapy and then after insulin therapy, how much he became clearly better looking, and he went on to live for 70 years, which is quite a lifespan for type 1 diabetes in those days. So the only treatment is insulin. And I think that's the first message from a practical clinical point of view. let me share with you our biggest challenge in the OPD. Invariably, this happens in children, the first couple of decades of life. Invariably, the parents and the child are both severely and easily understandably severely traumatized by the fact that they have this disease in which the child will require to receive multiple injections every day for the rest of their life, right? So their first question, and at the back of their mind, all their primary interest is there a non-injectable therapy for this disease? Now, what happens is some well-intentioned but uninformed neighbor or relative will tell them, I will take you to X, Y, or Z, who will help them give up their injections and they will be fine on oral medications. As a parent, this sounds an attractive proposition to them. They take their child, the injections are stopped, tablets are started, the person goes, because there is no endogenous beta cell reserve, goes into progressive hyperglycemia, diabetic ketoacidosis, which, if not recognized and treated early enough, there is a death, right? So the patient loses his or her life. And that is a very, very critical challenge we face as physicians, to try and convince the parents not to stop insulin. The second thing is to say, well, it's not going to work, but if you want to try something else, try it on top of insulin. Because if it works, we can reduce the dose of insulin. You know it's not going to work, but you've got to try practical politics in the outpatients department. Because if you don't convince them about not stopping insulin, the patient will die. There is no kinder and milder and less blunt way of putting it. But you don't say that to the patient's parents because they will not listen to you, but you've got to say that. The second thing which was clearly demonstrated with type 1 diabetes was that tight glucose control causes a significant prevention of microvascular and macrovascular complications, and also in those who already have early disease, prevents progression. So message 1, insulin. Message 2, tight control. This is what really happens in people who don't have diabetes, right? The first thing you'll realize is, even when they're not eating anything, it's not that their endogenous insulin levels goes down to 0. There is always some insulin circulating in the blood. This is there to help suppress hepatic glucose output, but it's there. The moment you eat a meal, there's a spike and it comes down sharply, right? So, two important observations: a continuous low level basal secretion of insulin, and a sharp rise and a sharp fall of insulin related to a meal. And therefore, our treatment regimens must try and replicate that. Right? Now, the problem is they don't, or not nearly as well. So what are the sorts of insulins that we have? We have conventional regular insulin, which was a zinc crystal dissolved in clear fluid. Basically, what happens with the regular insulin is that it is monomeric to start with, but once it's injected, 3 dimers combine together and form a hexamer. Then the hexamer has to break down back to become a monomer before it gets absorbed in the blood and takes and starts working, right? And this process takes about 30 minutes. So if you're giving conventional regular insulin, you must give it 30 minutes before a meal. But now the other problem with this is, you can see, when you give it, even if you give it 30 minutes before the meal, the peak is never as sharp as with a person who doesn't have diabetes, and B, the downfall, the decline is neither as sharp nor as complete, right? So you are having two problems, that if you wanted to get this peak to rise that high as it would have had in a normal person, then you are definitely going to cause hypoglycemia because it will come down but not come down totally. And secondly, in any case, you are likely to cause a hypoglycemia because 2 hours, 3 hours, 4 hours after the meal, you will continue to have circulating insulin, whereas the meal effect has been lost. So, two messages from here. If you're giving regular insulin, give it 30 minutes before the meals. And secondly, give a mid-meal snack, maybe 2.5 hours after the first meal, to counter this effect of persisting insulin levels, right? And that is very, very important for you to understand. So the mismatch between meal-related increase in blood glucose and insulin, the glucose remains high because you haven't really matched the peak which you wanted. And then there's a chance of low blood glucose 4 to 5 hours after injection. And therefore, 20 years ago or so, people started developing analogs of short-acting insulin. These have been modified so that they don't hexamerize, right? And therefore, the effect starts much earlier. You don't have to wait 30 minutes, 5 minutes, 10 minutes is enough. Number one. Number two, the decline in action is faster, so that by about 4 hours after the meal, there is virtually no, after the injection, there's virtually no persistent insulin in the blood, right? So the likelihood of hypoglycemia becomes less. However, because it totally disappears, there may be a tendency for the sugars to start drifting up after about 4 hours because there is no circulating insulin if the person is getting only a short-acting analog. I'm going to remind you here that I said there are two ways in which insulin is released in a normal person: a continuous basal insulin, and we haven't talked about that here because that needs to be provided, and a meal-related bolus, right? So these regular insulin and the short-acting analogs are working for like the bolus insulin. And there are different ones. There is Lispro, in which they have switched lysine with proline, which prevents this. There is insulin aspart, which they've replaced aspart at position 28. There's glulisine. Again, these are variations of one amino acid or two amino acids. And with that, you will find that this is a bit of a, I think it's a bit of a over-representation, but it's a reasonably good rise and a reasonably good fall. I don't think it's as good as normal, but it's better than what you see in regular insulin. So the advantages are there's a flexibility. You can inject and eat within 5 minutes. So you can shoot and eat. The blood glucose values after 1 hour and 2 hours after meals are lower than what you see with regular insulin. As you saw, the regular insulin doesn't peak that much. And if you want to achieve that peak, you'll be ending up with a much higher risk of hypo. With optimal additional basal insulin, right? So you must combine a basal insulin with your multiple shots of short-acting analogs. You can actually get a lower A1C, and the likelihood of hypoglycemia is considered to be less. Then conventionally, there used to be things called intermediate acting insulins, right? They are, you can say for the ease of remembering about, they act for about 12 hours, right? So if you give regular insulin before each of your major meals, breakfast, lunch, and dinner, and you give a bedtime shot of NPH, that really covers the whole day fairly well. And NPH is the commonest insulin which is done. However, we have now also started using long-acting analogs. One of them is glargine, which acts in most people for 24 hours. There's a change in isoelectric point towards neutrality so that the insulin is soluble only in an acid solution and then precipitates the moment you put it into the human body because the pH there is about 7. and then it has to slowly release from that depot in the skin. Insulin detemer, in which there is uh, there is albumin attached. There's a fatty acid attached which allows it to combine with albumin in the blood and prolongs the circulating half-life. And then insulin degludec, which is modified such that it causes multiple hexamers, right? So this is glargine. I won't worry showing you this. And this is degludec, which when injected, it causes multiple hexamer chains, which then slowly break down to cause monomers. So essentially different ways. Now, this table summarizes, and I'm sure a table like this or variants of this will be found in every textbook of pharmacology. But the important things you have to see is how soon does the insulin start acting for the bolus insulins, so that you have to give that shot that much time before the meal. When is the peak action? Because then you might have to give a mid-morning snack. And what is the duration of action? So for conventional regular insulins, as I said, the onset of action is about 30 minutes. So you need to give it 30 minutes before the meal. The peak action could be 2 hours, 3 hours, in some instances even longer. So if you have breakfast at 8, it's always a good idea to have a mid-morning snack at about 10:30 or so that you compensate for this peak action. And it acts clearly till the next meal, so you don't have any worry of an escape hyperglycemia happening. In contrast, the rapid-acting analogs, aspart, lispro, glulisine, act pretty fast. So you can inject, wash your hands, sit down to your table and eat, and that's fine. The peak action is early, but the duration is short. There is now an ultra-rapid fast-acting analog, which is called FIASP, fast-acting insulin aspart, which is even 3 minutes of onset, peak action within 1 hour, and a short duration. Then comes the intermediate and long-acting insulin, NPH, which starts acting in 1 to 3 hours, peaks at 5 to 6. Now, this is important to understand, because if you give NPH at bedtime or at 8 or 9 p.m., it'll peak at 2 a.m. or 3 a.m., which may cause a hypoglycemia. So giving a bedtime snack is useful. So even if you have dinner at 8, but you're going to sleep at 10:30 or 11, taking a glass of milk will prevent that midnight hypo. The others, whether they are detemir, glargine, or degludec, so detemir acts from usually 12, 14, 16 hours, but very rarely 24. Glargine and degludec will act for longer, right? So once a day shots for glargine and degludec. Detemir, you can start with once a day, but you may need 2. They're relatively peakless. So you won't get a peak dose effect, so you may not have that hypoglycemia as often as you may get with NPH. So in a person with type 1 diabetes, the standard treatment is a shot of regular or short-acting analog before each meal, and a bedtime shot of intermediate or long-acting insulin. You can give it by syringe, you can give it by pen, or whatever way you want. You can give it by pumps, in which you really need to give a short-acting analog, because if you give regular insulin, it'll aggregate and then it'll take time to get into action. So pumps use short-acting analogs. And what happens is you can tailor the basal infusion rates. It need not be the same throughout. So if you see that early morning hours, the requirement falls, you can reduce the insulin infusion rate. And the bolus can be controlled by the patient depending on the amount of carbohydrate in that particular meal. What are the complications of insulin therapy? Clearly, hypoglycemia. Clearly, the most important one is hypoglycemia. But remember, hypoglycemia, because of regular acting insulin, lasts less long than with the sulfonylurea. So if you have a person who comes with hypoglycemia to the casualty who's had regular insulin, control the hypoglycemia, watch for a few hours, they can be sent home. For a person who's had hypoglycemia with sulfonylureas, it's always advisable to keep them for 24 hours, because they may have continued hypoglycemia for the duration of action of that sulfonylurea, which is often much, much, much longer than the duration of action of regular insulin. The second thing is they cause weight gain. The third thing is that early in the course of treatment with insulin, you can find a worsening of retinopathy. This was noticed in early studies, but obviously as you maintain good control, this goes away. Insulin allergy is rare, especially in today's date when you have recombinant human insulin, which are monocomponents, and insulin site hypertrophy can happen if you keep injecting into the same site. There is what's called a lipohypertrophy because the fat starts accumulating. What about diet therapy in a type 1 diabetes? 6 meals is what we normally advise. 3 major, I shouldn't have used the word large here. So breakfast, lunch, and dinner, a mid-morning snack, a tea time snack, and a bedtime snack. Right? You should calculate the total caloric requirement based on their ideal body weight. So about 30 kilocalories per kilogram of ideal body weight. So if I'm 5 feet 4 inches, 160 centimeters, my height is 60, my weight is 60 kilograms, 1800 calories or so is fine. Low GI, that is glycemic index, foods should not miss meals. There is a flexibility based on the amount of carbs that you take, but then the patient should understand the principles of carbohydrate counting. So if they know that 1 unit of insulin is adequate to counter 15 grams of carbohydrate, and they normally take 45 or 60 grams of carbohydrate, but on a particular occasion they're going to have a heavier meal and the amount of carb increases, they can up titrate the amount of insulin dose. But that's a separate story and a separate discussion. The bigger issues are travel, keeping insulin in a handbag, not in a plane. It should not be in your check-in, and you should always carry more insulin than you require, because if you get stuck in some place because of a lockdown, you'll be in trouble. It should be stored in a cool place. If you have a refrigerator, the door of the fridge is the best place to keep the insulin. How do you monitor? You monitor by HbA1c and you monitor by home monitoring. So we have a standard way in which we tell patients to do self-home blood glucose monitoring. In children, obviously, you need to ensure not only glucose control, but you need to give them an optimal physiological environment so that they gain height properly. You must monitor for microvascular complications, so an annual fundus after the age of 10 years or 5 years after disease onset, especially after puberty, very critical. You must monitor for proteinuria, you must monitor for neuropathy, and you must be careful about lipids and any cutaneous infections. I won't tell you much about the pump except that it's a useful device, very expensive, even with the changes. The sort of pumps that you get are, one is in which there's no automation except that you have got to feed in all the rates. And in other instances, you can actually combine the pump with a continuous glucose monitoring system. So these are sensors which are implanted in the subcutaneous tissue, which can speak to the pump. And different pumps have different caliber. So in some instances, the pump, once it gets a message that a sugar value has reached, let's say 70, they stop delivering insulin. In other instances, the pump has what is called a predict mode. So you can, if the pump sees that the sugars have gone down, let's say from 130 to 100, and the slope of decline is continuing, it'll predict that in the next 10 minutes is going to go down to 70. So they stop insulin release in anticipation of that projected release, right? So these are lots of good things happening with technology, but technology is not cheap. Clearly, infusion, so continuous subcutaneous insulin infusion, or CSII, is something which brings tight control, reduces glycemic variability, And I think it is a useful addition, but it's obviously not available for everybody. I'm going to wind up by two segments, which are the acute metabolic complications, hypoglycemia and diabetic ketoacidosis. First, let's handle hypoglycemia because just talking about insulin. So hypoglycemia is in a person who's diabetic on glucose lowering therapy is usually defined as a plasma glucose which is less than 50. Different people use different definitions, but clearly remember your target for therapy, pre-meal target is 80 to 120. So at the moment it starts going below 80 consistently, you must titrate your agents so that you don't get hypos, right? The glucose threshold to develop hypoglycemic symptoms may vary from individual to individual, and the responses may also vary. The first set of these symptoms are sympathetic, so are basically autonomic, could be sympathetic, could be parasympathetic, and I'll talk to you about that in a minute. And the other thing you need to remember is any effort to have tight glucose control. For example, in the DCCT, there was a threefold higher chance of hypoglycemia in the tight control arm of the study. So it's important to remember, and this has to be explained to the patient so that they understand that there is a downside to attempted tight glucose control. So obviously there are certain risk situations. If you've given too much dose, whether insulin or oral agents, bad. The person has delayed the meal. There's been too much by way of exercise. Over a period of time, the insulin sensitivity has increased. So what's happened is when you started, the patient was overweight. With his or her efforts, the patient's weight has become less. They become more insulin sensitive. Therefore, an agent which was appropriate for a previous weight and previous level of insulin sensitivity has now become excessive, right? And then, of course, a big problem which we tend to forget is declining kidney function, because insulin clearance is based from the kidneys. And of course, in the oral agents, we've had a whole list of oral agents which are either passed as active or inactive metabolites from the kidney. So the autonomic features are adrenergic, so palpitations, tremors, anxiety, and cholinergic, sweating, hunger, and paresthesia. Okay? So that's the first level. These are warning symptoms. And they tell the person that, hang on, you're about to go into deeper hypoglycemia. And this is very, very important because with longer duration of diabetes, people develop autonomic neuropathy and they may not have these warning symptoms, so that their sugars continue to drop, these symptoms don't appear, and they directly go into what are called neuroglycopenic symptoms. So they start getting confusion, they may have behavioral changes, and they may actually have a frank seizure. So autonomic symptoms, adrenergic, cholinergic, primarily help because they are warning, and then the neuroglycopenic symptoms. How will you treat the person? Obviously, if they're not unconscious, you treat them with glucose-containing fluids. I specifically pointed out that you can give sugar, you can give other stuff, except if somebody's on acarbose in which glucose is mandatory. Glucose obviously will act fast. A reasonable initial dose is 20 grams of glucose, but remember, especially on oral agents, because you're likely to have a continued effect, it's always useful to first give a fast absorbed carbohydrate like glucose and then give another carbohydrate to have a sustained effect. Because a fast absorbed carbohydrate like glucose will then also tail off fast and they will go into another round of hypoglycemia. If they're in hospital, you can use a 50% solution, 25% solution. You can actually even give 10% dextrose. It doesn't really make a difference. Injectable glucagon and now nasal glucagon is getting available, which in a type 1 diabetes with hypoglycemia is a useful counter. Patients can keep it at home. It is also useful for the caregiver at home because if the patient is lapsing into unconsciousness, you can't give oral fluids because it may go down the respiratory tract and cause a problem. So give glucagon, which will counter the hypoglycemia and buy you time to get you to hospital where an IV infusion can be started. And let me come to the very last bit. I'm sure you're very happy to hear that this is about to end in case you were listening in the first place, is the story of diabetic ketoacidosis, which is an acute metabolic complication seen in people with type 1 diabetes. I have deliberately not talked to you about hyperosmolar coma because that's extremely rare. It's in people with type 2 diabetes, and you can read that up, whereas a DK is something which is commoner. So each of these three letters, D, K, and A, have relevance because it represents a triad of hyperglycemia, which is a D, ketosis, which is a K, and acidosis or acidemia, which is A. So to have a diagnosis of diabetic ketoacidosis, you need a blood glucose of more than 250, you need a pH of less than 7.3, and you need ketosis, which could be either ketonuria or you can do a plasma ketone because you have now point of care devices which measure beta hydroxybutyrate levels. So a beta hydroxybutyrate level of more than 3 millimoles per liter is consistent with ketosis. Anything between 1.5 and 3 is highly suggestive. To support acidosis, a diagnosis of acidosis also is a low serum bicarbonate, less than 18 milliequivalents per liter. Some people say less than 15 milliequivalents per liter. So what do we do with a patient who comes to us? You need to measure the glucose. You need to measure an arterial blood gas. If you can't measure an ABG, do a VBG. Remember, the pH difference between an arterial sample and a venous sample is 0.05. So if my VBG is showing 7.25, it means my arterial blood gas would have shown a pH of 7.3, right? At the same, so it's important that when you draw the sample, you also send electrolytes, creatinine, and you can measure serum ketones. If the patient is awake, they can ask pass urine and you can do urine ketones, or the plasma sample can be there for the ketone measurements. We often, because infections can be a provocative factor for causation of diabetic ketoacidosis, we will send a complete blood count, so hemogram, and a urine and blood culture, because we may end up deciding to start an antibiotic and a pre-antibiotic sample is useful. And ECG is useful because it's useful for us to pick up potassium level changes because you can get hyper and hypokalemia depending, and that also helps you monitor, take decisions about management. And a chest x-ray, as I said, because very often you can have an underlying occult infection. So that's what we do when we receive a patient there. The three critical parts of management are fluids, insulin, and potassium, right? So your aim is to correct the acidosis, your aim is to correct the hyperglycemia, and your aim is to correct the electrolytes. Obviously, you need to correct the precipitant. The precipitant in our setting could be, number one, the patient didn't know they have diabetes, so they're presenting for the first time in DKA, and that happens in about 30% of patients with type 1 diabetes. It can be somebody who went to a friendly neighborhood doctor who said, I can make you stop insulin. Just take these tablets, and they landed up in DK. They can actually not have done it knowingly, but they were traveling and their supply of insulin ran out, or they skipped a couple of doses because they were not feeling well. That also is possible, or an infection. So other than that, fluids, insulin, potassium, and before they're discharged, assuming you make them well, education so that they don't have another episode. So what are the broad principles? You need to be sure about airway, you need to be sure about breathing, you need to be sure about circulation. So the ABC of resuscitation change stays the same. Intravenous fluids for which normal saline, and I'll break this down a bit more in detail in the next 3 slides. Uh, Intravenous fluids in which normal saline is a fluid of choice. Intravenous regular insulin infusion after confirming serum potassium, right? Remember, somebody who has a low serum potassium to start with, if you give insulin, will become further hypokalemic. You can precipitate arrhythmias and create problems. So that's the next thing. You need to have evidence of the potassium status, and we often need to give potassium supplementation, but that is dependent on the availability of 3 pieces of information: a serum potassium as measured in the laboratory, passage of urine, so that if you give potassium and you overdo it, the potassium can be excreted, and an ECG which shows no evidence of hyperkalemia, because the ECG is a good marker for tissue exposure to potassium, right? So if you have low potassium, you must supplement with potassium before you start insulin. If you have normal potassium, you can start potassium supplementation along with insulin. If you have high potassium, don't give potassium, just start the insulin, but keep a watch on the potassium levels, right? So ABC plus fluid plus insulin plus potassium, right? Look out for and treat the acute precipitating factor. Monitor the vitals, monitor glucose 1 to 2 hourly, monitor electrolytes and pH every 4 hourly. It's a very labor-intensive job to manage a patient with DKA. So intravenous insulin infusion is needed for both hyperglycemia and ketosis. It brings down the hyper sugars, and it will cause removal of ketosis. Ketones are there because of excessive lipolysis and a mismatch between the insulin and the glucagon levels. So you need to give insulin. Sometimes what happens is that the sugars come down, but the ketones persist. And in that instance, you need to replace normal saline with 5% dextrose so that you can continue to provide glucose on the one hand, enabling you to or allowing you to give insulin, keep the sugars under control, but also cause clearance of the ketones. Once the DKA is resolved, that means your sugars are normal and your ketones have gone, and the patient is accepting orally, you can shift to subcutaneous insulin with the meal. But remember, you must give an adequate overlap. So if I'm going to start lunch, I will give my subcutaneous insulin before lunch, but I will continue the IV infusion for 1 or 2 hours so that I don't allow any, a hiatus between cessation of the levels, because remember, IV insulin will stop circulating within 5 minutes the moment you stop it, right? So you don't want this. You need to have a continuous exposure to insulin while your regular insulin takes over. So give subcutaneous insulin, start the meal, and continue IV insulation for 1 to 2 hours after that. So this is IV fluids. Look at the hydration status. We invariably require to give sodium chloride, that's normal saline. If for some reason, because there is a high sodium, you will then need to give a half normal saline, but we very, 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 very rarely require to do that. And as I said, once blood glucose reaches about 200 or so, you can shift from normal saline to 5% dextrose. Obviously, if the person is in cardiogenic shock, you will need to give pressors, and hemodynamic monitoring will have to be done. Insulin infusion, you give a bolus, 0.1 units per kg. So if I'm 60 kilograms, you'll give 6 units of insulin and then start an infusion at 6 units per hour. And you need a target fall of glucose about 50 to 70 per hour. If you, let's say I started with 400 and after an hour, I'm still at 380, I haven't had an adequate dose, double the infusion rate. I then measure again after 1 hour. If it started falling by 50, 60, I can continue the same insulin infusion rate. So you need to measure frequently and you need to titrate the insulin infusion accordingly. Once again, once the blood glucose reaches about 200, reduce the rate by half and or shift to 5% dextrose. Resolution of decay is defined as a glucose level of less than 200 and the ketoacidosis has gone. So the pH has gone above 7.3, the bicarb has gone above 18. Patient is neurologically alert and taking nutrition orally. The ketones may take a little bit more time to go away. The post-resolution management is if for some reason the patient is not taking orally, continue insulin infusion. As I mentioned, on resuming oral nutrition, shift to a multiple subcutaneous insulin regimen. So you're going to give regular insulin or short-acting analogs before the meals and a basal insulin, which is either NPH or a long-acting analog at bedtime. Continue your insulin infusion for 1 to 2 hours after the subcutaneous insulin dose. And I think this is my last slide, that the biggest message you need to give the patient before they're discharged is how to prevent any future episode of decay. So they need to be educated about diabetes. They need to be taught what are called sick day guidelines. And the sick day guidelines are never stop insulin. If you're ill, measure blood glucose 4 times a day. Continue to titrate your insulin dose depending on your sugars. If your glucose is less than 200, continue normal insulin. If it's more than 200 but less than 300 before the meal, add an extra 4 units. If blood glucose is more than 300 before a meal, add an extra 6 units to your regular dose. Drink milk, drink fruit juice, drink sugar-free fluid so that you don't get dehydrated. But if you're nauseated, if you're vomiting, and the blood glucose is persisting over 300, please seek medical assistance before you lapse into a full-fledged frank episode of diabetic ketoacidosis. I think I should be stopping here. Yes, I am. And I am happy to stay on for an extra few minutes if you have any questions. If you say I have none, I'm equally happy to leave you be and go back to doing other stuff. Thank you for being there for how so many people are there. And as I said, happy to take questions.
Yes, sir. It's fine. मैं बस साउंड बंद करता हूँ सर पहले सर इसमें साइन
इसमें क्या साइन करना है?
आपका अटेंडेंस स्टूडेंट अटेंडेंस नहीं है सर
मैंने यहाँ
ये
मैंने
सर
attendance किया।
वो अलग है
ये क्या है?
ये अटेंडेंस शीट है स्टूडेंट सर
इसका
अभी
क्या मतलब?
इसमें लेंगे ना सर अटेंडेंस ये
कौन?
हमने अभी लेंगे ना मैडम अभी नहीं मैंने करवाऊंगा ना ये देखो सर
वो सर रोल नंबर
मैं कहाँ लूँगा?
आप साइन कर दो सर नीचे
कहाँ साइन करूँ?
यहाँ इस यहाँ पे
अटेंडेंस लेते हैं आप लोग?
ये अपने यूजर नेम के हिसाब से रोल नंबर ऐड करते हैं तो उसके हिसाब से ऐड करते हैं
ये बट आप उससे कहाँ 16 पे साइन करा रहे हो? आज 15 तारीख है।
हाँ आज सर हाँ नहीं 16 डेट नहीं है सर ये तो सीरियल नंबर है
अच्छा चलो
आप डेट डाल दो सर ऊपर 34 बच्चे हैं सर देखो सर ये 34
ठीक है भैया
33 है
जितने भी है मुझे उसमें कोई रुचि नहीं है। आप ये सब कार्रवाई में मुझे एब्सोल्युटली कोई रुचि नहीं है। आप लोग करो, मैंने कर दिया साइन।
ठीक है मैम देखो जब मैम बाहर वेट भी कर रहे हैं 5 मिनट तक कर दो काम
कौन वेट कर रहे हैं?
थोड़ी सी मैक्सिमम
अभी तो टाइम है।
हाँ हमें सर अटेंडेंस देने में टाइम लग जाएगा ना सर
हेलो
3574 लिखो
यस हाँ बोलिए।
थ्री फाइव सेवन फोर एक मिनट में रुको।
हाँ हाँ
3574
मैडम का पूरे का होगा, उनको जो भी टाइटल था पूरे का दिया।
एक सेकंड जस्ट वेट।
जो भी पूरे का
3527
35
27
नहीं लगा, मैंने अभी अपनी हिंदी में
हाँ
ठीक है मैडम देखना अभिनव अग्रवाल।
अभिनव अग्रवाल और
ठीक है मैडम देखना अभिनव अग्रवाल दूसरा भी है।
एक ही अभिनव है यहाँ
एक ही है ठीक है फिर ये अदर्स अब 3517 ठीक है सर 3517
3517 ठीक है
3528
35 हो गया ये तो पहले ही हो गया
3538
3538
3540
3540 हाँ
3548 3554 3610 10 आगे लगाओ ना अगली लाइन खाने में
अरे अगली लाइन ये तो है
ठीक है 3568 3565 3545
35
3445 34
34 तो है ही
3445 होगी मैम
लाइन ही 35 से शुरू है
लास्ट में देखना फिर फेलियर हुआ है फेलियर
क्या बोला था एक सेकेंड
3445
हो गया
हो गया ना
हम्म
3574 3581 3611 मैडम है ना शान जडियाल है क्या
क्या
शान जडियाल ये है ना शान जडियाल देखना
शाम
शान जडियाल
हाँ हाँ
कर दो उसको प्रेजेंट और 3613
36
13 ठीक है और मैम ये हो गया इतने ही लग रहे हैं तो अब 15 ही रह गए मैं क्या करूँ उसमें ठीक है
चले
चले गए
क्या दिक्कत
ठीक है चलो ये इसे बंद नहीं करता ठीक है आप पेन करना
एक बार मेरे को बता दो
हाँ इधर इधर आ जाओ ना
अभी कनेक्ट नहीं है ना
कनेक्ट कनेक्ट है सिर्फ साउंड ऑफ आप बोल सकते हो आप
ओके ओके मुझे ना ये दोनों कराने हैं और चेंज हो सकता है बाद में।
और मैं बताऊंगा ना आपको।
हम्म,
देखना आपके लेक्चर कहाँ है मैम, ये है ना,
ये दोनों,
ये दोनों है, आप
नहीं
याद रखना।
ये और ये नहीं है।
ठीक है, पहले कौन सा खोलोगे? ये
बोन्स खोल देते।
ये खोलो।
हम्म,
आपने कुछ पूछना है मुझसे?
हाउ इज मतलब विजिबल
मैं
कैसे हो रहा है
ये
उनको?
सब मैं अभी दिखाऊंगा आपको।
हाँ,
ठीक है मेरा ये, और कुछ
मतलब मेरे को अलग से स्लाइड नहीं दिखेगी?
नहीं, आप इसमें देखेंगे,
अच्छा, सेम उनको ही वही
वो
दिखेगी।
उनको दिख रहे थे।
ओके, ठीक है। साइड में अगर कोई और ओपन करना हो तो नहीं हो सकता?
अब इसको फिर एस्केप करेंगे आप ये, ठीक है, इसको यहाँ से मिनिमाइज करेंगे और ये लेक्चर अपना खोल लेंगे,
हाँ, वो उनको दिख जाएगा।
वो इनको दिख जाएगा।
ओके,
बाकी मेरा रेडी है सब कुछ।
नहीं
ठीक,
मेरे को सिर्फ आपसे ये पूछना है, एक बार ये ओपन करना। अगर ये वाला व्यू खुला है तो उनको ये भी दिख रहा है?
नहीं,
सिर्फ ये दिख रहा
हाँ
है?
मगर ये अब देखिएगा, ये अब दिखेगा उनमें।
वो उसमें नहीं दिखेगा?
नो,
ओके,
ठीक है।
ठीक है। बैक चले जाओ, एक सेकंड, अभी स्टार्ट नहीं करना। ये ओपन फर्स्ट वाला करना। मैं अपना साइड में ओपन कर देता हूँ।
ठीक है, और आप यहाँ यहाँ रख लो ना इसे।
लैपटॉप को ना।
हाँ,
हम्म,
या इधर रख लो यहाँ पे।
हम्म, यू टेक अ चेयर एंड सिट।
अच्छा, आपको रजिस्टर देना, इस पे साइन मारना है मैम।
हाँ,
बाद में मारना ज़्यादा
हाँ,
समय।
ठीक है, ठीक है।
ठीक है, मैं आपको अटेंडेंस आपका देता हूँ डिपार्टमेंट का।
It is open both downwards and ठीक है। you do it like this, ठीक है।
ठीक है, चालू करो।
हाँ,
अब देख लो और कुछ और देख लो।
हम्म,
अरे थोड़ा इसको पीछे जाना, नहीं तो इसकी फोटो चली जाएगी, यहाँ रखो इसे। ठीक है, हो गया
ये
ना?
भी बैठ सकते हैं ना?
हाँ
ये भी
हाँ हाँ, बैठ जाओ, दिक्कत क्या है। आप लोग चालू करो ना। हैं?
एक मिनट, अब वो चालू हो
आप
गया।
मास्क मारेंगे ना उस टाइम पे, आपके आवाज साफ जाएगी।
अच्छा, मास्क
क्योंकि आप
लगाना
डबल,
पड़ेगा।
हाँ आप उतारे ना, इसलिए आप दूर दूर रह जाओ, बैठ जाओ।
एक बार देख लेते हैं, अगर नहीं आवाज आ रही बच्चों को।
मैं चेक करता हूँ, ठीक है, मैं साउंड खोल रहा हूँ अब। हाँ,
हम्म,
ठीक है।
स्टार्टेड। स्टार्ट हो गया ना?
हाँ, मैं देख चेक करूँ।
हाँ,
अब कन्या पूछ दो, बच्चे आवाज देंगे, रिस्पॉन्स देंगे।
ओके। एम आई ऑडिबल टू ऑल ऑफ यू? एम आई ऑडिबल नाउ?
बच्चे
Okay, today our class will be more of practical based. So first we'll start with the examination of bones. What is forensic osteology? It is the application of medical knowledge of bones for the purpose of law and administration of justice. So any human bones with the human tissue attached with it is called forensic anthropology. What is the need for examination of bones? For identification and analysis of skeletonized remains known to be or suspected to be human, such in cases of mass disasters, plane crashes, cyclones, earthquakes, in which body gets mutilated and burnt. What we can get from it? The race, sex, age, height, stature, whether the person was poisoned, injured, he was suffering from any disease or deformity. Now first, the race. It is determined by a cephalic index, which is maximum breadth of the skull by maximum length of the skull by 100. So here is a table given below. Cuscoids, mongoloids and negroids, where the skull is round, square and narrow respectively. And the cephalic index, the third point, CI, cephalic index for cuscoids is 75 to 80, mongoloids is 80 to 85, negroids 70 to 75. Now the determination of sex. If when the body gets mutilated in a mass disaster, and if you get only the skull of a person, it has the 100% accuracy to determine whether it is of male or a female. If you get a pelvic bone or a skull together, it determines 90% accuracy of the sex. If you get pelvis alone, then 95% accuracy is there. Skull alone, 90%, and long bones with 80%. Some books have mentioned as they vary the percentage of accuracy. Now we'll see the morphological features in a male and a female skull, where the general appearance of the in male skull, you can see it is larger, heavier, more massive, muscular margins are more marked than a female. See the orbits, orbital cavity, in which the male orbital cavity is small and square, whereas in female is round and circular. And see the shape of the mandible, it is square shaped. The chin, you can see it's a square shaped in male and rounded and U shaped, V shaped in female. Whatever I spoke was there in this table. The muscular ridges were more marked and less marked in female. Supraorbital ridges that I missed out was more prominent in male and less prominent in female. See the supraorbital ridges in case of a male. Now we come to the pelvis. The green line shows the pelvic brim or the inlet, we can say. Obturator foramen is the most important one through which you can make out whether it's a male or a female at one instance. The obturator foramen is oval in male and triangular in female. Just see the difference. Oval in male and triangular in female. And in black color, there is pubic arch. It is narrower in male and wider in female. Through this calipers, the subpubic angle is measured. The arrow you can see, it is 70 degrees on the protractor. The subpubic angle is V-shaped and Angle is 70 to 75 degrees in male and U-shaped, and angle is 90 to 100 degrees in female. This is the subpubic angle in a male pelvis. Now age estimation. Why we estimate age? For this is the medico-legal significance. You can read in your textbooks where the importance of age 7, criminal responsibility. What do you mean by criminal responsibility? It means if a 7-year-old child pulls a chain, pulls a train chain, he is criminally responsible for his act. If a 5-year-old child, while playing, pulls the chain of the train, his or her parents are responsible for his act. That's the difference. Importance of age 12. The child can consent for general physical examination. Importance of age 18. The child can consent for any surgical procedure. Now, what is the importance of age estimation in forensic? Any individual, relative, employee, police person, or any court person can give you a request letter to a doctor, to any doctor, to even to a MBBS doctor, to estimate the age of the given person. It could be either for administrative purpose or for criminal cases, in which, suppose in criminal cases, I'll give you one example. A victim of rape. Suppose if the age of the victim is less than 18 years, the act and the IPCs followed for the punishments will be under POCSO Act. Okay. Hope you know the POCSO Act. In court, civil and criminal cases where civil disputes of property or succession and contract. Now, how will you determine the age? First is the physical examination, that is by the body stature, secondary sexual characters, height, weight, everything. Second is the dental examination. I won't go into the detail because my topic is related to only bones. This is the Gustafson method, important for your theory exam. Now the radiological examination from the bones. The process of appearance and union of union of fusion, they follow a sequence. Okay. Now these are the 4 rules that we follow. First is just look at the picture. You'll see in first left hand side you can see the center has not appeared, and the second one there is no union, and there is a head of humerus and the shaft has a broad thicker line in between, and there is that thicker line has reduced the space and shows the partial union. And when this thicker line unites, it gives a white thicker line on X-ray. It suggests of recent union. And when there is no white line, it suggests of complete union. I'll show you same on the X-rays. Look at the pointer pointing towards head of femur, the down part. Is the line of union appreciable? Just look at the head of femur. Okay. Is it appreciable now? Here the head of femur is not united. So, but the center has appeared. This is an X-ray of elbow joint. See the olecranon process of ulna, where the non-fusion is there. Can you appreciate a black line and a white line? If any doubt, please ask. See, lower end of radius, right side of wrist joint, you can see the AP anterior posterior view, lower end of radius and ulna. There, everybody can appreciate the non-fusion of the lower ends. Non-fusion suggests that the X-ray is of a person who is below 17 to 19 years. This is upper end of tibia and lower end of femur. This everybody has seen this X-ray. Now the appearance of ossification centers in a wrist. Everybody knows the mnemonic. She looks too pretty, try to catch her. So the first carpal bone to appear is capitate, and the second one is hamate. At 2 years of age, there will be only two carpal bones. And then after, as the year gets advanced, the number of years suggests the number of carpal bones is equal to the number of age in years. So 3 years of child will have 3 carpal bones. 4 year of child will have 4 carpal bones, and 5 years will have 5 until 6. All the carpal bones except the pisiform. Pisiform will be appearing in the last. For humerus, the head appears in 1 year, lesser tubercle in 5 years, greater tubercle in 3 years. Medial condyle in 5 to 7 years, lateral condyle in 11 years. Now I have made a schematic diagram of radius and ulna, where the arrow is pointing somewhere, going up, then diagonally, then again up. It forms a shape of a N. So lower end of radius appears at 2 years of age. Okay, then follow the arrow, the upper end of radius 5 years, then lower end of ulna 6 years, then 9 years upper end of ulna. This is only a memory aid. Head of femur, which we saw in X-ray, appears in 1 year, greater trochanter in 4 years, and for a memory aid, if you add 1 and 4, 14 for lesser trochanter. Lower end of femur comes in 9 months of intrauterine life. We saw that N was formed with radius and ulna. Now U is formed with tibia and fibula. This is also a memory aid. 0 stands for at birth. At birth, the upper end of tibia will appear. And 1 at 1 year of age, lower end of tibia and lower end of femur at both at 1 year, upper end of fibula 4 years, forming a U. All these fusions are important to estimate age. Here you can remember parts of sternum. There is manubrium, 4 parts of body, and xiphoid. So there is total 6 parts of sternum. First two is 5 months of intrauterine life, second also 5, then 7, 7, 10, and then 3 years of age. You can remember as 7, 7, 5, 5, 7, 7, 10, and then 3 years of age. The above ones, all they appear in intrauterine life. Xiphoid get fused at last around 40 years of age. So the xiphoid will not be fused in all of you. Now fusion of major bones. S stands for the shoulder joint, elbow joint, W for wrist joint, hip joint, knee joint and ankle joint. First, the elbow joint get fused at 16 years of age. Then hip joint and ankle joint gets fused at 17 years of age. Shoulder joint at 18, wrist joint in the last 19 years of age. Now, if you get a one single bone, femur, and you have to estimate the height of a person, and you have to recreate a stature of a person with the help of one single bone, how will you do it? There are some bone specific factors for each bone given over here, and two formulas are there. One is Carl Pearson's formula, other is Torter's and Glessler's formula, in which the length of the bone, whatever the length of the bone you got, whether it's a broken bone or complete intact bone, whatever the length of the bone you got, measure the length into that bone specific factor. If it is of male, add the bone specific factor for male, plus the one fixed factor is there to rule out the errors. It will give you the stature. So there are two formulas, Carl Pearson's, Glessler's. This is the osteometric board in which the length of the given bone is measured. This osteometric board has a scale. This is a complete intact bone. Even if you get a broken bone, you can measure the length. Now these are the possible questions that will probably come into your practical or theory exam. First is determine sex from the given skull or pelvic bone, and at least 6 points suggesting that supporting the given sex of that bone. Medico-legal significance of age, difference between temporary and permanent teeth, describe in detail Gustafson's method, bony index to determine race and sex. Is that clear? Now the bones part is over. Last topic, weapons and soft parts. What are the different types of weapons? Blunt weapons, sharp weapons, mixed variety, and firearms. These are the blunt weapons: the cricket bat, stump, baseball, walking stick. Okay, this will be kept in your practical exam, and the question will be like, what is the type of weapon? It is a hard and blunt weapon. And what are the injuries possible by such weapon? Abrasion, contusion, patent bruise, railroad patent bruise, ectopic bruise. What do you mean by ectopic bruise? Ectopic bruise means when the bruise is produced on a part of a body where, but the hit is on some other part of the body. Other than the hit, the bruise is produced. Fracture of skull and extremities. MLS. What do we mean by MLS? Here, this word you'll be hearing, all the way medico-legal significance. All these objects and weapons can cause simple and grievous hurt, can also be used for homicidal purposes. This is whip. This is hard, blunt, and flexible weapon, can cause abrasion, contusion, laceration when struck with the handle, may be used for strangulation also. It can be used for homicidal purposes by repeated strikes, strangulation, and for torture. This purple color rope is available in our museum, can be kept for your practical exam. And the mark, the brown color parchmentized mark you are seeing is the ligature mark around the neck. And the weapon is hard, blunt, and flexible. This rope, common method for suicide. Homicidal and accidental reports are rare. This radiological image shows fracture of axis 2, C2 vertebra. This is most common in judicial hanging. Metallic knife. Now, what kind of weapon is this? Curved knife. This is sharp, single-edged weapon. Sharp and single-edged weapon. By the sharp edge, incised wound can be produced. By the tip of this weapon, punctured, penetrating or perforating wound can be produced. By the blunt edge of the handle, see the blunt edge, abrasion and bruise can be produced. This is dagger. It has a double edge. It is sharp and has a double edge. Injuries are same like the previous one. This is similar to hammer, locally called as basuli. The one edge is sharp and the other edge is blunt, and it comes with the detachable handle. And the medico-legal importance is it can cause simple and grievous hurt. This is X, sharp, heavy weapon. Now the firearm. Firearm is classified into two, rifled and smooth bore. The rifle, what is the difference between rifle and smooth bore? Rifle has alternate lands and grooves. You can see this is called rifling. It gives the motion to the bullet. And smooth bore has a smooth bore completely. The bigger one, the shotgun wad, is used in this smooth bore weapon, and the smaller bullet is used in rifled bore weapon. You have to read about the contents of these cartridges. In this picture you can see this is the entry wound caused by shotgun. Multiple marks of pellets you can see. This is hyoid bone. Everybody knows the parts of the hyoid body, greater cornu, lesser cornu. It gets injured in traumatic asphyxial deaths, most commonly seen in complete hanging. tattoo mark. What is the medico-legal significance? Identification. Some has the religious pictures encrypted. Most of the drug abusers have extensive tattoo marks over the upper limbs. Method of removal. Corrosive agents can be used, electrocution or surgical methods. This is washerwoman foot. Sodening and wrinkling of the skin. It is seen in cases of drowning or prolonged immersion of foot or hands in water. It can be either antemortem or postmortem, both. I just added this picture. This is normal kidney. Now, this is lacerated kidney. It is caused by increased in intra-abdominal pressure following the blunt trauma. Blunt trauma could be either due to road traffic accident or fall from height. Medico-legal importance is accidental, homicidal. This is another specimen of lung showing consolidation. The acute causes are pulmonary edema, pneumonia, or aspiration, and chronic are neoplasm, lymphoma, sarcoidosis. This is a specimen of fetus in our museum. The age of this fetus is 4 to 5 months of intrauterine life. Questions will be asked, what is the age of the fetus? In 4 to 5 months, the features would be, you can appreciate whether it's a male or a female. So sex can be differentiated. There will be very, very thin and light lanugo hairs. Head is 1/4 of the length of the body. So head is larger. Umbilicus is situated near the pubis. Pupillary membrane just appears. Meconium found in duodenum. Now I'll show you the difference between the term fetus. Here the scalp hairs have grown longer, about 2 to 4 centimeters. The hairs, lanugo hairs disappears. Nail grows beyond the tips of fingers and toes. In case of a male child, both the testes will be present in scrotum. Meconium, which was in duodenum in 4 to 5 months, will reach up to rectum. Umbilicus, which was near the pubic symphysis, now comes upwards, is present in midway between pubic symphysis and xiphisternum. The red arrow, this is a specimen of a heart. The red arrow shows stab injury in heart. The internal findings during the autopsy will be, the pericardium will be completely blood filled, will be showing the features of cardiac tamponade. Now this is a specimen of skin showing incised wound. Can you appreciate? It has clean cut margins, has 3 dimensions, length, breadth and depth, and has sharp edges. Now these are the hesitation cuts. It is also a type of incised wound. What is the medico-legal significance of incised wound? This incised wound, you can get the idea of the type of weapon or the method used. Can you appreciate tailing downwards? That tailing can give you the direction and the relative position of that victim and accused. Hesitation cuts are suicidal. Defense wounds will be seen in homicidal cases where the victim tries to defend himself in struggle. I just wanted to show you the difference between the stab wound and incised wound. In incised wound, the length is larger, and in stab, the depth is greatest. We have heard about the three wounds earlier: puncture, penetrating, and perforating. Puncture means any any puncture wound that enters the wall and but does not enter into the cavity. Same like vaccination puncture mark or injection prick mark. It's a puncture wound. Penetrating wound, it enters a cavity without exiting from that cavity. And perforating wound, it is a through and through wound which enters through the wall and exits through the cavity. Carefully see all these specimens. Don't get scared. The below one shows the tongue, and the midline cut section is the trachea attached. So blacks, here you can see the black soot particles in trachea in cases of burns. So question regarding thermal injuries can be asked on this specimen. It is a hallmark of antemortem burns. Absence of soot particles is seen in when the incident has occurred in open area, or if the mouth and nostrils are closed, or if after the incidence of burns he has been hospitalized for a long time. This is a specimen of heart showing crush injury. It can be caused by a grinding force or compression of chest caused by either fall from height, railway track accident, CPR, blow from an industrial factory, or any accidental run over. Most important one, this is the specimen of brain attached with dura. The white color polythene like structure is the dura, and see the red arrow mark showing the hemorrhage, epidural hemorrhage. It is above and outside the dura mater and below the skull bone. Source of bleeding is middle meningeal artery. It is always traumatic in origin. Even if the patient is fine, the doctor should keep him in observation for 24 hours because symptoms can develop even after 48 hours, which can lead to concussion and coma. So, if a doctor is discharging a patient uh, before 24 hours, he can be sued for negligence. This is subdural hemorrhage. Subdu the gloves is holding the dura, blood stained dura. This hemorrhage is under the dura mater but above the arachnoid. The bony flap is removed from the right side and you can see the subdural hematoma. The source of bleeding is dural venous sinuses. Now, how will you differentiate between subdural and subarachnoid? This is subarachnoid hemorrhage. We will wash this part of brain with water. If the clot gets washed away, it was subdural. And if it doesn't get washed away, the blood clots uh, inside the sulci and gyri you are seeing is called subarachnoid, which may be traumatic and spontaneous. Source of bleeding, rupture of bridging veins near sagittal sinus or rupture of berry aneurysm. This is the coronal section of brain showing the intraparenchymal bleed. The above questions can be asked. What is the difference between subarachnoid and subdural bleed? This is cross section of cerebellum showing intercerebellar hemorrhage. The hemorrhage is not very well appreciated, but the yellow part, if you can make out, is the intercerebellar hemorrhage. Okay. Now these are the possible questions which can be kept in your practical exam. First is, what is lucid interval? What is lucid interval? It is the interval in which it is a normal time period of onset of symptoms and injury that has occurred. Read about its medico-legal significance, difference between incised and stab wound, difference between rifle and shotgun cartridge, morphological changes to determine the intrauterine age of fetus, what is penetrating, perforating and puncture wound, difference between entry and exit wound, what is abrasion collar, components of gunpowder and its various types. So these are the possible questions for your practical exam. Thank you.